Good morning, bom dia a todos. It's my pleasure to welcome you to this strategic high-level FAPESP webinar on COVID-19. International experience on reproduction number, government response, and limited testing. We are fortunate to have with us a panel of international experts who will bring timely and accurate information for all scientists and policymakers to make better informed decisions. Therefore, first of all, allow me to thank all the speakers for their active cooperation and support to help and nurture Brazilian science. At the beginning, Professor Luiz Mello, who is the Scientific Director of FAPESP, will address some words.
Good morning all, and thank you, Rui, for your kind introduction. This series of webinars that FAPESP will be holding in an attempt to contribute for instigating scientists and bringing up what would be the relevant questions and discussions to be potentially addressed and developed as solutions for the current pandemic. We are honored to have a distinguished panel of speakers, both international and national speakers. And without much more, I'll just hand the word back to Professor Maciel for us to continue. And thank you for the speakers for accepting the invitation.
Thank you, Luiz. During the presentations, please feel free to send questions to live@fapesp.br, and our guests will reply them at the Q&A session. In addition, this webinar will be taped and available on YouTube immediately after its end. Our first speaker is Dr. Cécile Viboud. Cécile Viboud is a staff scientist at Fogarty International Center at the National Institutes of Health, where she's part of the multinational influenza seasonal mortality study. Viboud specializes in the mortality of infectious disease. During the COVID-19 pandemic, Viboud was part of international efforts to collect, curate, and disseminate epidemiological information about SARS-CoV-2. The title of her presentation is COVID-19 Modeling and Surveillance Approaches. Please, Dr. Viboud, go ahead.
Great, so thank you very much for the invitation. And I'm looking forward to hearing more about the COVID-19 experience in Brazil and sharing some of our findings on COVID-19 in other settings. Can you see my screen?
Yes. Yes.
I'll just make it a little bigger. Right, okay. So I'm in the in-house research division that focuses on infectious disease modeling at the Fogarty International Center at the NIH. And today I thought I would focus on two different themes. First, transmission modeling to look at the impact of interventions, and this is primarily based on Chinese data. And in the second part of the talk, I'm going to talk about time series approaches applied to surveillance data. So starting with transmission modeling, in early January of 2020, we started a nice collaboration with Dr. Hongji Yu at Fudan University to look at the dynamics of the epidemic in different Chinese provinces. And one of the first things we were interested in quantifying changes in reproduction number over time. So here we're looking at data for one of the provinces, Shaanxi, which is a neighbor of Wuhan and Hubei province, where the epicenter of the epidemic was. And we have the time series of cases by date of symptom onset at the top here. The pale color is for locally acquired cases, and a darker color is for cases that are imported. So one thing to know about the epidemic in China is that it was very well controlled very early on, and actually few provinces had such sustained transmission. This is one of the few that I'm showing here. And if we're looking at the reproduction number here, making sure we separate out the local cases versus the importation, we see a period of rapid growth up to about 2.5. And then on January 23rd, a lot of interventions were put in place, including strong social distancing, and the reproduction number quickly drops below 1, where it stayed so far. So we've also been looking at the impact of social distancing on contacts. And so we've looked at that in 2 cities, Shanghai and Wuhan. I'm only looking at the Shanghai data here for the sake of brevity. But our colleagues in China did a really nice contact surveys before the pandemic. So this is kind of a peacetime contact survey on the left here that we're seeing. And it's the kind of traditional age-specific contact matrix where we have age of a participant on one axis and age of their contact on the second. And in this matrix, before the pandemic, you see the traditional very strong diagonal here in children, which represent contacts within schools. So darker colors here mean more contacts. And then you see sort of a swath here of darker colors, which represent contacts during in the workplace. And then some off-diagonal terms here, which are contacts between parents and children. So this is the usual situation, not a pandemic time. And then the same type of contact survey was repeated during the time of the outbreak, during the period of social distancing. And you see that there is a sharp decrease in contacts. The total number of contacts decreased 7 to 9-fold in Shanghai and Wuhan. And all of the contacts at school disappears, the contacts in the workplace disappear too. And traditionally, outside of the pandemic period, you have many more contacts in children than you have in adults, but here there's no more difference between age groups in contacts. Everyone meets 2 people during the day. Basically, it's just household contacts. And the graph on the right just represents the difference. So basically, you're eliminating schools and workplace. And so this is very detailed data that's kind of difficult to get at because you have to interrogate people about their contacts. But at the same time, there's been a lot of data on mobility, which is more of a population level indicator of contacts. And here in Shanghai, you see that there's about 70-fold mobility drop after January 23rd, relative to historical years, which is consistent with this 7 to 9-fold decrease in contacts. We can then feed those contacts into age-specific models of transmission to see the impact of social distancing on disease dynamics. So on the graph here on the left, we're looking at a baseline R0, so kind of a non-intervention R0. So for COVID-19, we're probably between 2 and 3 here. And on the y-axis here, we have the R0 under different intervention. So the red line is the R0 that we're getting during the period of social distancing in Shanghai. So you can see that from an R0 of maybe about 2.5, you drop down to close to 0.4 during the period of social distancing in Shanghai. So a really, really strong decrease in R0 because of social distancing. And those 2 lines here in black and blue represent different school closure scenario. And so clearly that school closure is not enough to completely stamp out the outbreak, but you do reduce transmission quite a bit. And the 2 scenarios depend on whether you assume that schools, there's no contacts among children, or there's still some contacts because there's some residual activities that still occur. On the right-hand side, we see those scenarios, their effect on the dynamic of the epidemic. So the orange one is the non-control epidemic, very sharp, intense outbreak for R0 2.5. And then if you apply school closure, you do see a reduction in transmission, a lower peak, which might help with the hospital surge capacity. But if you're looking at the on the right-hand side here, there's a little bit of a reduction in total infection rate, but it's clearly not enough, probably to be to a level that will be tolerable to public health authorities. So this is one of the work that showed that school closure is not enough, but many other groups have shown similar things. So this was social distancing, so really, or lockdown, so really blunt instrument. But we're now looking at the impact of case-based interventions, and in particular, contact tracing. And this is again data from China, but this time from Hunan province. And so we see here the epidemic curve in Hunan province. It's mostly driven by travelers, and then there's a little bit of secondary transmission. And overall, there's about 1,000 cases, and all have been very closely monitored and traced for their contacts. And so because of this very detailed data on contact tracing, we can reconstruct chains of transmission, which we see here for those 900 plus cases. The different colors represent different locations within Hunan province, different cities. And the size of the nodes represent how many secondary cases each case will generate. So clearly you see that a lot of cases don't generate any secondary cases, but some generate quite a few. And the histogram on the right here shows you the distribution of secondary case per index case. So it's a very dispersed distribution, which is reminiscent of what we saw for SARS-CoV-1 many years ago. That most cases don't generate any secondary case, but some might generate up to 9 here in this data. But the mean is 0.64, so it's a relatively low R0. And again, this is a situation where there's a ton of contact tracing, so this is not an uncontrolled outbreak, explaining the low R0 here in this data. So then we can look at the predictors of transmission in this data. So we're basically looking at a regression of all of the index case and their contacts. Some of their contacts will progress to being cases. And so we see here the effect of socio-demographic factors. And in particular, we see that if contacts are younger, basically under the age of 18, there's less of a probability of acquiring infection, suggesting that children are less susceptible than adults. We don't see any factor of sex. And there's maybe a bit of a suggestion that children are also less infectious than adults, although it's not significant. And then we can also look at the impact of severity, clinical severity of the index case on the probability of transmission. So that's what we see at the top here. And the only difference that we see is that asymptomatic cases seems to transmit less than symptomatic ones, about half, although confidence intervals are large but significant. And then whether you're a mild case or a severe case doesn't seem to matter very much. At the bottom here, we see the effect of the type of contacts. I mean, clearly we think that if contacts are more intense, that favors transmission, and this is what we see in the data. The top 3 here, as for household contacts, are at different times of the epidemic. So phase 1 is before social distancing. Phase 2 and 3 are after social distancing. Phase 3 is social distancing and intense contact tracing. And what we see, interestingly, is that the household contacts favor transmission, particularly in the period of social distancing. And we think this is because in the period of social distancing, people spend more time at home with their household members. And so there are more intense and longer contacts than usual. And then all of the other types of contacts, family, social contacts, contacts through the transportation system, have a reduced effect on the risks of transmission, which makes sense because those are less tight contacts. And then the other thing that seems to matter is the duration of exposure. And that's particularly for household contacts. And for every additional day you're in the same household has a case, there's a 4% increase risk of transmission. We can also look at the residual heterogeneity in secondary cases. One, we've taken into account all of these factors here. And so that's the histogram that you see here, the expected number of secondary cases once all of those factors have been included. And there is less heterogeneity than in the data that I showed you earlier because we've controlled for a lot of things. However, there is still some residual dispersion here that's not explained. So we can also try to titrate when transmission occurs over the course of infection through this data. So on the three graphs here on the left, we're just seeing how intense basically contact tracing is. So the number of days after symptom onset that the case is isolated. And so you see that in phase 1, so early on in the epidemic, cases are isolated on average maybe 4 days after symptom onset. But then as the epidemic progresses, they're isolated earlier and earlier down to phase 3, where there's a significant proportion that are isolated before symptoms. And that's through contact tracing. The only way to isolate cases before symptoms is if you contact trace them. And so we can also look at the fraction of transmission that occurs before symptom onset. Overall, we see that about 50% of transmission occurs before symptom onset in this data. However, that really depends on how fast you're isolating the index case. So if you just focus on the bottom of this graph here, if you isolate the index case on the day of symptom onset, by definition, all of your infection occurs before symptom onset. But if you isolate cases later and later, then you have less and less transmission before symptom onset. And in the case that's perhaps the least control here, where you're isolating index case quite late, 6 days or more after symptom onset, you get about a third of transmission before symptoms. So we think this is the best estimate for the uncontrolled pattern of transmission, that maybe there's a third before symptom onset. We can also see that cases are as infectious a few days before as a few days after symptom onset, and that seems to match with some early viral shedding data we have, where shedding seems to peak at the time of symptom onset. So the last bit of this work is to try to infer whether contact tracing alone would be able to stamp out the outbreak. And the bottom line is that it would be difficult because it's a relatively high R naught, and there's quite a bit of transmission before symptoms. So on this graph here, we're looking at the speed of case isolation. So T0 is date of symptom onset. So here we isolated cases after symptom onset. Here we're isolating them before. Clearly, if it's before, it's because of contact tracing. And then on the other axis, we have the intensity of case isolation, what fraction of cases we're detecting through our system. And the line here is the line of R0 equals 1, so the line of control. And you can see that if on average, maybe you're isolating cases 2 days after symptom onset, which seems relatively reasonable. If you have just symptomatic surveillance, then it means you have to find about 90% or more cases, which is a lot. If you're able to isolate them on the day of symptom onset, you still have to detect about 70+%, which is still very high. So basically, it's quite difficult. However, we think that there will be contact tracing in a lot of places, along with maybe a tiny bit of population level interventions. So this is what this graph is trying to look at. So if you have a little bit of help from population level intervention, perhaps a 10 or 20% decrease in transmission, and you can think of this as maybe schools being closed, or maybe a little bit more telework than usual, or maybe just because there's more immune people from the first wave. In New York City, for instance, we have 20% of immune people after the first wave, or perhaps just a little bit of a decrease in transmission in summer. So if you have this little bit of help from population level effects, then you only need to find about 50% of the cases here through contact tracing, and that seems more manageable. This is also for a relatively low baseline R0 of 2.2, which is based on a new analysis of the early growth rate in Wuhan that's adjusting for the increase in detection, plus a serial interval of 7 days, which is where we find in our data. So it's a relatively conservative view of R0, but of course we can make those graphs for other scenarios. So in the second part, I'm just going to swift through some digital surveillance and excess mortality approaches, which are more like time series analysis rather than mathematical modeling. So there's been about a 10-year interest in using digital surveillance, which is the idea of using Google searches, Twitter, and other social media to try to predict infectious disease outbreak. This is an example from a recent work that we did in Africa to look at flu patterns. And so here are 4 years of flu data for South Africa. The black line is the ground truth epidemic curves, and the other lines are different models. The red one being a model that uses Google terms as well as an autoregressive approaches. And we can see, if we look at the errors of these different types of model, we can see that Argo, so the model with Google Trends, does a little bit better than any of the other approaches. And so has a little bit of predictive power in the order of 1 to 2 weeks in those flu data. We can do the same for other countries, Ghana and Algeria. The errors are bigger for those 2 countries. There's also less data. Internet coverage is a bit lower. And so there's clearly an effect of sample size and data quality here. So the way those algorithms work is that you're looking for a number of search terms that might be related to flu, such as cold, bronchitis, flu, swine flu, etc. And you allow each coefficient to vary over time. So on this heat map, we have coefficients over time. But just to show you that some coefficient pop in and out of this predictive model. Blue means highly positively correlated and red highly negatively correlated. The one in the middle here is swine flu in this case. So this was flu. How about emerging infections? Emerging infections is probably most similar to COVID-19. So we've tried that too. This is looking at yellow fever, Ebola, Zika, and plague. The black is the epidemic data provided by the public health surveillance system. And then the different colors are different models, the red being the Google-based model. And the first thing that's important to note here is that the black data, if you compare the black against the gray, which is the ground truth, so the epi data at the very end of the epidemic, you see that there's quite a bit of difference. And that's because there's backfill and correction in the surveillance data. And that's a phenomenon that's pervasive in every surveillance system. And we can see that the Google model helps remediate this backfilling and sort of inaccuracy of the data, and allows you to better nowcast where you have. So perhaps it doesn't look very much in the future, but at least it's able to look at it closely, give you a better idea of where you are. There are cases where it doesn't work as well. I mean, plague in Madagascar, as you can see, the patterns here are not well reproduced, especially early on. And then the Ebola outbreak is also difficult to reproduce. So basically it tells you do need a little bit of data, and like every situation is different. So we're now applying this to the COVID-19 outbreak, both in Pakistan and South Africa. This is an example from South Africa. The epi data, the ground truth, is in green, and the Google model is in light orange. And so what's interesting here is that you see that there's a decline in flu-like illness in recent months, particularly in March and early April of 2020 in South Africa. And that's because they went on lockdown very early. And so we think this has affected, I mean, basically COVID-19 hasn't been progressing very much yet. So the nice thing we're doing here is we're looking at flu-like illness, but we're removing the contribution of flu positives and RSV positives. So we have the unexpected, unexplained fraction that presumably will rise once COVID-19 starts to transmit in South Africa. And this is what we would like to predict using those approaches. I'm just going to skip through this briefly. This is the same type of coefficients over time, just to say that whenever we apply it to a new country, we try to use English search terms because it's actually used a lot in a lot of countries, but also local search terms. So we're using Africans here in South Africa and Urdu, for instance, in Pakistan. So last little bit, we're looking also at their outpatient visit data in South Africa through their medical claims, so fitting seasonal baseline to this data and looking particularly at the recent weeks here on the right-hand side, which is where COVID-19 is predominant. And we see an excess of consultation in recent weeks, both in the 20 to 49 years old and in the 50 and over. And it's been very important to communicate with the public health teams in South Africa, because they are interpreting this as just a worried-sick bias, not really as an intense transmission of COVID-19. And they don't see anything in the inpatient data. And the only reason I'm showing this is that I know that Brazil has really good hospitalization and mortality data. And this is kind of the thing that could be done also, I think. The last little bit is about mortality. And so we've been looking at excess mortality in the US. So we have a few years of data here. The gray is the baseline, and then the black is the observed. And we're looking particularly at the period here in March and April 2020, where there's a rise of a baseline, which is the contribution of COVID-19. So the idea of this deviation from expected mortality is that it captures both the direct and indirect impact of COVID-19, including the lab confirmed cases, but the probables also that have not been lab confirmed. It can also capture decrease in unrelated causes, such as traffic accident or air pollution, which are just trickle-down effect of social distancing, as well as increases in undiagnosed or uncared for conditions such as myocardial infarction or maybe cancer that have not been detected. And so we can do this geographically. So we're looking here at different states. You can see the epidemic was quite heterogeneous across states in the US, early and sharp rise in New Jersey and New York, quite an early rise in Washington state, but that was quite addressed early on, and then later rises in other places. So we see that some states capture most excess death, Washington state, and that's one of the states that tests the most in the US. Some states captured excess death quite late, and that's Florida. Again, testing was ramped up very late in Florida. We see that only 50% of deaths have a COVID-19 specific code. And nationally, excess death represent about 1.5 times the official death counts. So there's about a 50% under ascertainment. The huge thing to take into account in these mortality data are the reporting lags. There are more lags than in traditional surveillance data. And so there are statistical approach to try to adjust for that. And there is a lot of interest in the US and other countries about the direct and indirect effects, especially air pollution, traffic incidents, cardiovascular disease, etc. And that's it for me. And thanks for your attention. I'll be happy to take questions when the time comes.
Okay, Dr. Viboud, thank you very much for your very interesting presentation. So let's move on. And so I'll be delighted to present Professor Michael Levitt, who is Professor of Structural Biology at Stanford University. And he is the 2013 Nobel Prize in Chemistry for the development of multi-scale models for complex chemical systems. Since January 2020, Levitt, his Stanford group, and an international team of volunteers have worked very hard on data analysis of COVID-19. Professor Levitt will talk about data determined growth rate of COVID and similarity with flu. Please go ahead, Professor Levitt.
Do you hear me?
Yes, very good.
Okay,
very well.
Great. And here's my desktop. So let me just say that after hearing Dr. Viboud's talk, I sort of feel that I'm here as being the educated layman in the room. I am not an epidemiologist, and in spite of a great deal of web searching, I still don't know how to calculate R. I do realize that that the growth rate depends on R plus the period infectious, but I think that for something that has infected so many people, we need a little bit of basic understanding. So please, may the epidemiologists forgive me. I'm going to just say a little bit, I think that will help other people understand. So firstly, just a little bit about exponential growth. All of this is really unnecessary. Here's my model. The blue dots are people, one gets infected and so on. And as long as you can find new people to infect, you will grow exponentially. But of course, in reality, we don't always move around. We don't mix freely. and therefore finding new people to infect is difficult. So exponential growth is not necessarily what always happens. Many models that involve networks and things like this do not lead to exponential growth. You really have to make an effort to shuffle everybody to get exponential growth. So in some ways, I think the widespread or the exponential spread of the term exponential did a great disservice to the world. Okay, so let me just now say something about exponential functions. And again, this is completely unnecessary for anyone who knows about functions. Exponential growth on a log scale, this is a log scale where you have going up by factors of 10, is just a straight line. Exponential growth means that the growth rate doesn't change. That means that the growth rate shown here in blue, which is just the slope of this line on the exponential scale, is fixed. With exponential growth with no limitation, at some point, the number of cases just shoots up. So this is a truly terrifying phenomenon. We went up from maybe 3 cases to 1 million cases in a period of 2 weeks with pure exponential growth. Really, really scary. Of course, you can make the exponential growth less scary by doing what I just call limited exponential growth. We set up some kind of false barrier. The growth gets to here and stops. And in that case, the growth rate, which is flat, i.e. exponential, suddenly goes down. And the number of cases now no longer goes up, it comes down. So this starts to look a lot more like what we're seeing. Now, of course, this is a totally artificial function. I just set a wall up here. As the virus is growing along this line, it has no idea it's about to hit the wall. And this is some kind of social distancing or whatever put in at this stage. Let's look though at, so just to give my conclusions, pure exponential growth is a terrifying phenomenon. Limited exponential growth is much less frightening. Epidemics may or may not grow exponentially. And again, there was a very strong impression given to all the public that this epidemic is exponential. Part 2, curve fitting. Very early on in my work on this, and I should say that I got involved on the 26th or 7th of January through contact with friends in China. A WeChat message of 2 pages of analysis went viral. Somebody leaked it out to Chinese Facebook essentially, and I then had to continue to do things. But it was clear from the ratio of the number of cases and number of deaths today divided by the same number yesterday, a very, very easy thing to calculate, that things were slowing down. Now let's just look at curve fitting. And I'm very, very proud to do curve fitting. When I talked about curve fitting to my Stanford colleagues, they said, he's not a modeler, he's a curve fitter. I should just say that I got my Nobel Prize for modeling complex phenomena. I can write code really, really well for my age, and I know all about modeling. But I also have learned from years and years and years of working in biology labs that in biology, you need to look at the data, and looking at the data is curve fitting. Also, we hear a lot about machine learning. Machine learning is just multidimensional curve fitting. That's all neural networks are doing. So we should not ever, ever, ever poo-poo curve fitting. So here is an example of curve fitting. We're going to look at 2 functions, the sigmoid function, which is a very symmetrical function, and the Gompertz function. They look identical on the scale here, where I simply have a linear scale going up 20,000 cases, 40,000 cases, and so on. It's obviously much, much better to look at these things on a log scale so we can see the details over here, and then they actually look very different. So the sigmoid function on a log scale actually looks like this. It grows exponentially, and then it stops. It looks very much like the exponential growth running into a barrier. This is the function used. This function is very, very common. It's also actually used as a bias function in neural networks. And essentially, we see that the number of cases goes up like this. The rate of growth, which is just the slope of this curve, is flat and then goes down. And it's a very nice symmetrical peak here for the number of new cases, which is shown on the right-hand axis, which is a linear scale. So this is now starting to look like some of the data. Another function, which I love very much, is called the Gompertz function. And the reason I love it is it was discovered and published 200 years ago in 1825. It's it's a very simple form, an exponential of an exponential. And on this function, on a log scale, it looks very different from the sigmoid function. And what is really interesting about this function is that the exponential growth rate is continually decreasing. From day one, the first case you mentioned, no intervention, nothing, the growth rate is decreasing. This is like a bank that offers to pay you 100% interest the first day, and then 50% the next day, and 25% the next day, and so on. That you will not make much money from a bank like that. You will not infect too many people. This virus, or at least the Gompertz function, is a situation that is slowing down from day one. And new cases actually on this axis is a little bit asymmetric. There are more new cases after the maximum than before. Okay, just to compare those. So the actual functions on a log scale look very different. This one is growing exponentially for a long time. This one just comes shooting out and is slowing down all the time. The growth rates are very different. The sigmoid function is flat and then trailing off. The Gompertz function is a straight line on this line. And again, my growth rate is just the slope of the log of cases, a very, very easy thing to calculate. That's also equal to the log of the number of cases today divided by the number of cases yesterday. Anyone who's had a little bit of school mathematics will realize that the log of a ratio is the difference of the logs. Okay, so let's now, again, different growth functions have different properties. Some grow exponentially, others do not. And this may have implications for the growth and control of epidemics. So now let's think about real data. And I guess I deliberately tried not to start with China. I've had a lot of feedback from people saying that all Chinese data is manufactured, is fraudulent, etc. I personally do not believe that. And in some ways, Dr. Viboud has started out by really using Chinese data, using her colleagues at Fudan. I also have connections in China. Unfortunately, the extramural part of the NIH, I'm not inside the NIH as Dr. Viboud is, frowns very much against any collaboration with anyone who is not in the USA. So we were hampered in this, but I'm going to do something, just look at a couple of places. First place is South Korea. No one minds about South Korea. And in South Korea, I'm going to first just show the number of cases as in terms of days from the 1st of January. And this is the thing. So you see in South Korea that there were actually multiple outbreaks. An outbreak here, another outbreak here. This is only 6 people. Another outbreak that got to 30 people, another outbreak, and finally, the outbreak we're going to fit. So again, in South Korea, which had this wonderful reputation of controlling COVID, they had many, many outbreaks. An important thing to realize. Okay, so now we go to the actual data. We're now going to show the number of cases. Well, it goes up like this. The first case recorded in Korea, and I'm just using publicly available data coming from the Johns Hopkins repository on GitHub. The first thing they recorded was 62 cases. It jumps up. Now, the important one is this one. What does the exponential growth rate look like? Is it flat, like the sigmoid function, or is it? Well, I think you'll all see that without any smoothing, that's a pretty straight, nice line. And of course, the number of cases is much more noisy because the number of cases is the number of cases. This is the number of cases per day, forgive me. The number of cases per day is the number of cases today minus the number of cases yesterday, and that's very, very subject to noise. Put a curve through this. That is the fit of the Gompertz function. That is the fit of the Gompertz function to this. So a single parameter fit, essentially, because there's a total number, a rate constant, and a time fit the data very, very well. This is in South Korea. Let's try somewhere else. New Zealand. Again, you can see I'm not trying to fit China, although the fit to China is even better than any of these. Well, again, in New Zealand, in spite of their claim of great control, they had a small outbreak, up to 10 people or 6 people, I think, and then a much larger outbreak. In fact, there's another outbreak over here, but this is how the Gompertz function fits the majority of the data. The data looks like, started earlier, very nicely curved line. In other words, this whole thing about flattening a curve is nonsense. The curve is self-flattening from the very first day. This is the slope of this curve, and this is the number of cases. Fitting that, beautiful fit there, straight line fit there, and a very nice fit there. So basically, we see from the data that from the very first confirmed case, the rate of growth of COVID is not constant. In other words, the growth is never exponential. Instead, the constant exponential growth rate is itself decreasing exponentially. I actually said this on the BBC on about the 18th of March. No one paid any attention. I should also say that I've been sending my reports, 23 reports in all on China and a few more on the USA to everyone whom I could get. And nobody ever engaged me in any discussion. I had to go to Twitter to get any kind of meaningful discussion. So how is this possible? I think I understand how it's possible. I'm not going to say that now. It could be an answer to a question, and perhaps Dr. Viboud could help with this. And how does it affect the control of the COVID epidemic? Let me now just change direction. I should point out, well, I do like working on data. Much of what I've done has been done by myself, but I'm sort of a data person. So now we're going to change direction and say, let's compare flu and COVID. Okay, so this is another database. It's the Euromoma database. This is Europe. It covers most of Europe that had bad COVID attacks, a population of about 250 million. The number of deaths per week is around 50,000. So the death rate is around 10 per 1,000. And here we're going to see that there were two outbreaks in exactly the same database. One was influenza, which spanned the 2017, 2018 calendar year. And then there was COVID. This data is actually a week old. And in 2 hours, I'll have the updated data. And I understand issues of delays and all of these things. So again, because of my ignorance, I'm very much into sanity checks. I should say that one of the problems with this data is they do not release the data. In order to get the numbers of this curve, you have to do mouse over. So essentially, if I put the mouse over there, I would see that on week 14 of 2020, the total number of deaths is this, and then I would get the baseline by clicking here. It turns out that they have a bug in their program, and instead of giving the baseline, this gray curve here, they actually give the upper limit. So therefore, you have to realize that and correct for that. There's a lot of work that needs to be done, and it's hard because you have to do many, many mouse overs. Okay, so let's just first ask, do Euromoma excess deaths, how do they relate to COVID deaths? So I simply took the total number of reported deaths for the Euromoma area in the Johns Hopkins database for every day, and that looks like this. And then I said, what was the reported Euromoma death rate for weeks? And I'm not sure whether I used the beginning of the week or the end of the week, and maybe that was my mistake when you do that. Firstly, they're exactly the same height. So the total excess deaths found in Europe is within, I think, 2% of the sum of all the cases reported up till that date. Now, I realize that there are days in recording and everything like this, but I was amazed at how these two totally independent measures fitted. We also say that I think we all realize that Europe was very, very badly hit, from northern Italy to Spain, to France, to Britain, to Netherlands, to Belgium, and to Sweden, that is not imposing very much in terms of controls. So let's go on. So when you do all this, what you find is that essentially the total number of excess deaths here done properly comes to 153,000. And when you take the excess deaths from the last 3 weeks or 4 weeks of 2017 and the weeks of 2018, you find that the flu excess deaths in the flu peaks. So I'm just simply looking at the excess deaths from here to here, and the excess deaths from about here to here. Okay. So when you do that, you find as a bottom line that there were 15% more COVID excess deaths than flu excess deaths. But for me, the really big surprise was the age profiles. What you find is that for COVID, about 50% of the deaths are people over 85, and only 8% of the deaths are people under 65. And to my amazement, using the same database, all the information from the same place, we find almost exactly the same thing for flu. Flu is about 50% over 85 and 81% under 85. In fact, in order to get this it was not possible to get the age ranges here very easily because of this lack of a baseline correction. I've been trying to email Euromama for weeks to ask them to get more data, but they are very unresponsive. I guess most people are very unresponsive right now because they're overflown with information. Okay, so I actually feel that this is very interesting. We do see this plateau, only 15% more than the 17-18 flu epidemic with the same range counts. But I should emphasize, and I want to say this again and again, COVID-19 is similar to flu, only in total and age range excess mortality. Flu is a different virus. We have a safe vaccine for flu, and it's much less of a threat to the heroic medical professionals. Thank you all for your attention.
I appreciated it very much. So let's move to our third presentation, which is about modeling COVID-19 infections and reproduction number based on
Excuse me, did you hear me, or was my microphone off?
No, perfect. Yes.
Thank you very much. Good.
Okay.
Could you stop the share your screen, Mr. Levitt, please? Thank you very much.
Okay, so Samir, Bhatt, and Thomas Mellan are at Imperial College London. Samir Bhatt is senior lecturer in geostatistics, Faculty of Medicine, and his interests lie in the development of an application of mathematical models to address policy-relevant questions about infectious disease. And the presentation will be done by Thomas Mellan. Please, Tom, go ahead.
Yeah, thanks very much. Is there anything you'd like to say, Sam, to give a bit of an introduction?
Yeah, I can start off and then hand off to Tom. I mean, this is very much Tom's work and his brainchild, so I'll just bring in a brief introduction. So essentially, it's great to follow from Michael's presentation because that's exactly where we started from, where we're very much statisticians and we wanted to think about how we can fit accurately to data. Now, obviously, curve fitting always has its place. What we wanted to do was to try to develop a halfway house, because in a perfect world, the exact mechanism to something or something very close to it, say modeling the swing of a pendulum, and you've got all the causal mechanisms in there. That's the best case scenario. Worst case scenario, you have to put in some arbitrary functional form, like a neural network. The best thing that we can do is something in between. So we don't use case data, we use death data. The reason we don't use case data is it largely reflects testing. It suffers tremendously from under-ascertainment, which as Cecile just said, before, it's exactly that with deaths as well, but it's far worse with cases. So if we move on to the next slide, Tom. Our main goal was to estimate the attack rate and the reproduction numbers. Now, what is the attack rate? Well, the attack rate is basically the number of people that have been infected. And a lot of this has some sensitivity to do with the infection fatality rate. But one of the primary things we wanted to actually model and figure out was the number of infections, which is not just the number of cases that you observe in the data, clearly, because of all the other issues I just mentioned. And the second thing we wanted to estimate was the reproduction number. Now, the reproduction number is famous now, everyone knows about it, but you can just think of it as the transmission rate or rate of transmission. Or even it can be converted to the growth rate, as I messaged Michael about that just before. And so there are many ways to try to figure this out, right? There's genetic analysis, where we can use phylogenetics to go back and try to figure out what, reproduction numbers were at different points using things like skyline plots, etc. We can look at seroprevalence surveys, where we actively go do a survey, almost like a poll, to measure the proportion of people infected. We can rely on population surveillance, which, if it's good and we understand exactly how the data is, then yes, we can use that in scenarios like China. Or we can use the reported number of deaths, which is what Tom and I use. And particularly for countries like Brazil, which Tom will be talking about, this is what we think is the safest way to do this. And these reported deaths are by no means the best, sort of without error. But the fact that they are already with error means a lot of the other data that you would want to use are difficult to sort of reconcile in models. So if we move to the next slide, I'll just talk through our brief about the statistics, and then Tom will go into actual detail about the mathematics. So when we started this work some months ago, what we wanted to look at were these things called age-dependent branching processes. We wanted to see a stochastic process modeling infections. So one person infects a certain number of people more, and try to figure out, what that stochastic process looks like. Now, age-dependent branching processes, 1948 was one of the most famous ones by Bellman and Harris. But essentially, we calculate the expected value of the generating function of an age-dependent branching process. That's the most principled. So we're starting from a stochastic process and defining an infection process that way. When you calculate this expected value, you get something that's called the renewal equation, which is extremely popular in mathematics everywhere. And essentially, the renewal equation is something very easy to understand. It's just saying the number of infections today is some function of the infections previously, i.e. the previous infections have caused these infections. And that's how we're calculating it with the renewal equation. And finally, we do everything probabilistic. So we do everything with a full Bayesian methodology, where we're not just simulating one scenario or one growth rate or one realization. We're simulating thousands and thousands of probable scenarios, of which the data could probably be produced by one of them. And so to go into the gory math details, I'll pass over to Tom, the physicist.
Yeah, thanks very much, Sam. So just to reiterate what Sam said, the approach that we take is principled in that we're working from first principles that one person infects another, and this infection occurs at some random period of time, and there's a random number of people that's infected, and we derive a renewal equation which just relates by convolution the number of cases now to the number of cases in the past. So I mean, perhaps you could have guessed this, but I mean, if you can afford principles, it's nice to have them. And in this instance, we can derive this deceptively simple expression for the number of cases now is equal to the number of cases in the history multiplied by some generating function that generates these infections. So just to get a bit more into the details of how our method works, before I present to you some details on some of the results that we've got from the approach for Brazil. Let's have a look. So the expression I presented before, the convolution relating the number of cases in infection now to the number of cases in the past was, as I said, deceptively simple. We can expand that a little bit to make it into a form that's more interpretable to epidemiologists and more useful for what we're doing. So we break it apart, and that generating process G, we say, let's have that as the temporal part of the infection process. So this will be a probability mass function or probability distribution. And so what this tells us is how infectious an infected individual is over some range of time. So the number of cases at some time t for some indexed here in our model for some country or for some state is equal to the number of cases in the past summed over all of those cases in the past, taking into account the temporal part of how infectious they are. So this is the basic convolution, and we've taken out some factor here. So this is now a probability distribution. We've taken out this factor, and this factor is the effective or time-dependent reproductive number, which in this model directly means the number of cases you would, secondary cases you would expect an average individual to result in. And this is something that changes both with time and that changes with geography. So this is really the central equation to everything we're doing. There's a schematic of the model presented here on the right-hand side, which perhaps is useful to give us a bit more of an overview. So we're modeling infections. We have some temporal distribution, a serial interval distribution, which is this G. And going into the modeled infections, we also have a time varying or effective reproduction number, here denoted R. And going into the model, we have different sources of data, which I'll talk about a little bit more in a second. So we have data from different covariates that we can try to build in, and data from deaths. So just to clarify a little bit on this expression before I move on. So our reproduction number here, RT, our time-dependent reproduction number is the basic reproduction number. So that's going to be the reproduction number at the start of the epidemic. Plus, we're going to give it some parametric form. Now, we try to keep things really as simple as possible. So we want to build some structure into R, the reproductive number, structure that makes sense, but at the same time, keeping things really as simple as possible. So in R, we really just have a simple linear model of some covariates. And these covariates are going to be things like how mobile, can we measure how mobile the population is? Have there been government interventions to say there should be lockdown? So stuff like this, we can build this in to give the reproduction number some structure. Although, I mean, perhaps this seems a little bit arbitrary, but we can, I mean, and simplistic, but we could equally replace this with a much more flexible form, for example, a Gaussian process, or something even simpler than all of these different covariates we've listed here. What we find is, in fact, it doesn't really make too much difference, and that the overall conclusions are broadly the same. So it's good to go with the simplest that's possible. So just some kind of technical details here. So for our infectious temporal distribution, we're using the serial interval distribution. We're using a gamma distribution with a mean of 6.5. And we also have this factor S, which accounts for the number of susceptible individuals that are in the population. So as people become infected, we assume those cases are removed from the reservoir of possible cases that can be infected. Okay, now the second key part of the model that I want to come to, that Sam has already mentioned, is that we are not directly fitting to cases. This is because the reported cases, they're not randomly, statistically well measured. They don't account for asymptomatic. The cases are subject to a number of biases in terms of age, well-documented economic biases in terms of the reported cases, specifically in Brazil. So what we use instead, that we think is a better measure, is deaths. So to come back to what Michael said, we are fitting, and we're fitting not to cases, but we're fitting to deaths. So how do the cases relate to the deaths? Again, we have a time domain convolution. Deaths at some time t in some country m are related to cases that have occurred previously, times some temporal distribution, some kind of death distribution here denoted P, and times an infection fatality ratio. Okay, so just to say that for this distribution, which says your likelihood of dying at some period of time after becoming infected, this is derived from parameters that our colleagues at Imperial College have worked on, so, or from the literature. And we know that the time distribution from becoming infected to seeing symptoms is about 5 days roughly, and is well described by this gamma distribution. And similarly, the time from symptom onset to death is around 17, 18, 19 days. So together we can estimate the time from infection to death as specified here. Okay, so that's the kind of the basic mathematical outline of the model. I've already emphasized to you that we don't use case data, rather we work with deaths because we believe the COVID measured deaths are probably more reliable. But we also try to include as much data from other sources that have a meaningful mechanism. So one source of data that we've included, apologies, sorry. One source of data that we've included for the latest work on Brazil is the change in mobility, which is measured from mobile phone data, in particular from Google mobility reports. So these are extremely useful, and we're fortunate to have these broken down by state all across Brazil. So, I mean, maybe I can just give you a little bit of an introduction to what you're actually looking at here. So this is the change in mobility relative to some baseline. And we look at the mobility in terms of different things. So how much are people staying at home would be this green line. So we can see there's a bunch of interventions happened in Amazonas. These interventions were government interventions where there was a state of emergency declared. That people were told to stop shopping, or shops were closed and schools closed. And around the same time, we see an increase in the amount of time people are spending at home. We see a decrease in the amount of time people are spending at their work. So this is all, I mean, perhaps stating the obvious, but you know, of course, mobility is expected to be a significant part of contact and affect viral transmission. So something that's perhaps interesting to note about Brazil is we see these big spikes for parks. So parks, parks just mean any public space. So this could be beaches, and we see these spikes around the 24th in Brazil, which I believe is a holiday, and there's a carnival around that time. So that's just to explain what this spike is. Okay, so let's have a look. So some Brazil-specific considerations that we try to take into account. So we've used this model, and we've used it in Europe. We've adapted it for Brazil and some other places. In particular for Brazil, we try to take into account the fact that the infection fatality ratio that we observe in Brazil will be different to China, or different to the UK or France or Italy. So we account for differences in the age pyramid. So I think we're comparing the UK and Brazil age population pyramids here at the bottom. Brazil is a somewhat younger population in general. So that's something that can have a big effect. As we know, this disease strongly differs in outcomes by age, but also accounting for this difference in infection fatality ratio. I mean, it's not just the difference between Brazil and China, or Brazil and the UK. Brazil is an enormous country, to again state the obvious. And even within Brazil, there are substantial differences in average age and age structure from one state to another. So this is something that we've incorporated into our model, along with trying to account for differences in contact patterns that comparing South American country to what might be expected in a European country. And also to add a little bit more structure to the variation in infection fatality ratio across the different Brazilian states, we tried to account for how we think there might be poor hospitalization outcomes. So we know that in UMIC or LMIC countries, there are poor hospitalization outcomes for COVID-19 due to access to high flow oxygen and ventilators. So we might expect some variation across different states in Brazil, whether they're poorer or richer. So that's something that we've tried to include in the model to an extent. Something else is underreporting, and this is not really specific to Brazil. It's something that's ubiquitous for COVID-19, but massively varies from country to country, and we expect it is probably substantial in Brazil. It's very difficult to estimate the degree of underreporting, and also to deal with the lags in the death data that we suspect exist. So all we can do is perform sensitivity analysis on the results and try to examine whether or not our conclusions change or not. Okay, and I think I've already mentioned the sort of spatial heterogeneity that we try to include in our model through looking at mobility covariance at the level of states, and also adapting the infection fatality ratio at the level of states. So I think we can have a look at some specific results now. So this is for Sao Paulo state, and this is the kind of thing that we're seeing with our model. I think this data is maybe yesterday, so it's slightly out of date today, but there will be no substantial changes in the conclusions. So just to break down what we're saying here, we're seeing the number of daily infections that we are predicting from our model shown here in this blue line. And you can see that this vastly differs from the number of reported infections, just underscoring to some extent, you know, the really sizable underreporting that's going on, 4 cases at least. So these cases are estimated from the number of deaths using the convolutions that we described, while being informed by mobility covariates. So the kind of thing that we're seeing is, I mean, number of infections is pretty high now. The number of daily deaths in Sao Paulo state is continuing to rise. I mean, this is really just describing the statistics. But really the most important thing, perhaps in this analysis, that I'd like to emphasize is that consistently we're seeing a reproduction number. So the reproduction number, if you just to repeat myself, is the number of, in this instance, it's the number of secondary cases that we expect an infected individual to result in on average. So this reproduction number characterizes whether the epidemic is under control or whether it's growing. And in every instance in Brazil, and consistently, we see that the reproduction number is above 1, suggesting that, I mean, just to break this down a little bit for you, we have the different interventions labeled here as they occurred in Sao Paulo. And we can see that there was some preemptive change in the reproduction number, and it sharply dropped at the same time as the government interventions. But it did not quite drop below 1. So although there was a substantial drop from around 3, it doesn't go below 1. And this is in sharp contrast to what we've seen in other European settings. So generally in France, Spain, UK, after non-pharmaceutical governmental interventions like closing transport and lockdown, we see that the reproduction number drops below 1. And when the reproduction number drops below 1, this really means things are under control and the number of daily infections will drop sharply. And the number of deaths, some period of time later, will start to drop. Okay, so let's look at somewhere a little bit south. So the same 3 plots again, daily number of infections, daily number of deaths, and the reproduction number. Again, we see the same trend, very different state, but we see the same trend that the reproduction number seems to be slightly above 1, suggesting the epidemic is not quite under control. Rio Grande do Sul is very different in terms of how progressed the epidemic is. If we look at the numbers at the bottom, the attack rate, so the total number of infections that we're estimating so far, is below the 1% level. So we're seeing a lot of inhomogeneity across the different states of Brazil. So, in some states, for example, Amazonas, we suspect the epidemic is at a very advanced stage, but irrespective, we're still observing that the reproduction number is slightly above 1, suggesting things are not quite under control yet. Something just to note, though, is no matter what state we look at, whether it's the most extreme state, for example, Amazonas, where the attack rate is very high and the epidemic has been growing very quickly, it doesn't matter what state we look at, we still see that the attack rate and the total number of infections that have resulted so far are quite far below what one would need for herd immunity. Given all the assumptions surrounding herd immunity, we're still very far off that. And we see that this conclusion is pretty robust, no matter what sensitivity analysis we do, whether we're having 50% underreporting of deaths, we're still seeing that we're quite far from herd immunity in every state in Brazil. Okay, so just a sort of final point is that we can try to identify whether or not the different mobility covariates, for example, people spending time in parks or people staying at home, are which of these are the most important. So unfortunately, it's quite difficult to estimate this, and we're getting very wide credible intervals. We can see that all of the different mobility interventions that people in Brazil have undertaken, whether it's staying at home or avoiding transport, they do have some substantial measurable effect, but it's not quite possible for us in this analysis to identify any single particular effect. It is notable that the parks seems to have a big reduction actually in the reproduction number in Brazil, but I think this may be the effect of parks is perhaps overstated in Brazil a little bit more compared to other places due to the effect, due to the carnivals that we've seen earlier in the year. So just to sort of finish up and really stress the different limitations, and there are a number of limitations in this work, and we're acutely aware of these in the model and really would like to highlight them. So in terms of the data, we're very aware that, I mean, we're reliant on the data that we receive from the Ministry of Health website, which is very good and it's broken down by state, which is excellent and useful. But something we do worry about is that there is systematic underreporting, just like in other countries, and that there is a lag. So naturally, this will affect the precise quantitative numbers we're predicting. But in terms of our sensitivity analysis, we're still drawing the same conclusions. Other things that it would be nicer to have would be to start trying to look at a city level in Brazil. I mean, even looking at state level, states in Brazil are very large, and we see very big differences in terms of you know, whether or not you're living uptown in a city or rural within a state. So it would be nice to try to break things down a bit further. In terms of the model, there are a number of things that would be nice to include. So we've parameterized our reproduction time model in terms of mobility covariates. Of course, mobility is not the only factor that affects transmission. If there was some way to build in non-mobility covariates into that as well, that would be very nice. So, I mean, I think it was Cécile who was showing the Google search analysis. So, I mean, that's something that would be interesting to consider as well. Okay, so I mean, I think I will just draw some conclusions, and perhaps after that chat, Sam can chip in and we'll finish up. So main conclusions are across Brazil, although we're seeing different states at very different levels of the epidemic in terms of how advanced it is. No matter what state we look at, we're seeing reproduction numbers slightly above 1, suggesting that the epidemic in Brazil is not under control, and that although the changes in people's mobility have been effective in reducing that reproductive number, they haven't reduced it to the same extent that we've seen in places in Europe, for example. And just also to reiterate that no matter what state we look at, we seem to be quite far away from herd immunity. And finally, just to point out that we're quite reliant on the death data we receive. So if there's lags in receiving this data, this will of course affect our capacity to predict. So we really would like to emphasize that keeping this data stream as up to date as possible is massively useful in trying to understand and characterize the extent of the epidemic in Brazil. Thanks very much.
Okay, Tom, thank you very much for your wonderful presentation, and points out the heterogeneity in our country. So let's move on, and I will call Pedro Hallal. Pedro Hallal, besides being professor of epidemiology of the Federal University of Pelotas, is actually the chancellor of the university. But now, he's leading studies on the epidemiology of COVID-19 in the state of Rio Grande do Sul, but looking to Brazil as a whole as well. So please, Pedro, go ahead.
Thanks, Rui. Can you listen to me properly?
Yes, very good.
So I will share my screen. So first of all, let me thank FAPESP for inviting me to this very interesting webinar. So pretty much what I will do is to present data on the descriptive epidemiology of COVID in Brazil. And apparently, colleagues from the Imperial College were unaware of some of these data, and particularly the Rio Grande do Sul state data. They are in a pretty advanced stage. They are already in medRxiv. We have 3 waves of data collection. So there are data that are trustable in terms of number of cases and estimates on infection fatality rates and things like that. So pretty much what I will do is to show you what our group is doing in terms of hands-on field work, epidemiology work for COVID-19 in Brazil. And obviously we are happy with collaborating with colleagues from the other universities, and there are lots of Brazilian researchers doing studies on COVID-19, and it would be great if they would be included in some of the models that were ran, because there are lots of information in Brazil that were left out. So first of all, I will talk about the EpiCovid study in Rio Grande do Sul, which is the state that is near Uruguay. It's in the extreme south of the country. And we designed a serological survey, repeated serological surveys in the state of Rio Grande do Sul. We sampled 90 sentinel cities representing each of the regions of the state, and cities are listed here. And it's like a big effort. So it's a partnership between among 13 universities funded by government and civil society agents, and with partnership from the Ministry of Health and the state of Rio Grande do Sul government. So, and the main thing that I want to start saying is that, Jeffrey Rose said very early on that epidemiologists need dirty hands, which is not easy to say nowadays. I would say dirty shoes because of all the washing hands thing, and a clean mind. And pretty much what we are doing in our epidemiology group, led by Professor Cesar Victor and others, is doing like real life field work, going to people's places to test them and to check what the status of the epidemic is in Brazil. So these are just 2 examples of pictures taken in the field work. So we are testing people from all ages, and obviously the picture on our my right hand side of the slide is probably the cutest we can get in the study. So pretty much what we have done so far is that we have completed 3 waves of data collection. So the first one was in mid-April, 4,200 people. And then the second one was towards the end of April, 4,500 people. And then the third one was in May, 4,500 again. And then this weekend, we are doing the 4th wave of data collection. And we already received funding to do at least 4 more waves of data collection. They take place every 2 weeks. And the government and the funders are interested in having more data because the prevalence of people with antibodies in Rio Grande do Sul is still very low. And obviously, we are interested in tracking the epidemic from baseline towards the end of the 1st wave. So we will continue to do surveys every 2 weeks until we have the end of this first peak of the epidemic in the south of Brazil. So, and this is the summary of our study so far. So the proportion of people with antibodies is very low. So it's pretty much 1 infection every 2,000 people in the 1st wave, every 769 people in the second wave, and every 450 people in the third wave of data collection. But if you go and compare the estimate from the survey with the official statistics, you will have the 10 times rule that many places are getting. Spain got more or less that, then other studies are showing pretty much the same. So if you want to know in the south of Brazil what is the real number of people who have been infected or are currently infected, pretty much what you need to do is to multiply official statistics by 10, and you have a very good estimate. All these numbers obviously have confidence intervals that are presented in the articles that I submitted for publication. I'm just presenting, you know, the face values here, and there are lots of other things we are doing, adjusting for the sampling of the clustering of the sample, adjusting for the specificity and sensitivity of the test, but these are like just the face values for now. And this is our data on social distancing, and this is comparing the 3 waves of data collection. So, you know, here we are interviewing people and asking them about how much they are moving around. So in the first phase in mid-April, 20% of them were going out on a daily basis. So pretty much they were kind of normal life. It increased to 28% in the second wave, and then to 30% in the third wave of data collection. So people are going out more over time. And then if you look at the green part of the graph, you will see that the proportion of people stating that they are at home all the time has decreased from 21 to 16%, which does mean that people are less compliant with social distancing and physical distancing recommendations from city, state governments, and some from the federal government. But in addition to the state of Rio Grande do Sul, we are also doing the same study for the entire country. And this is a map with the 133 cities that were part of our sample. And this is EpiCovid Brazil. So just to explain how they are selected, so both at the state level and at the country level, these cities are the largest city from each intermediate region of the country as defined by the Brazilian Office of Geography and Statistics. So Brazil is divided, let's say, in 3 levels. So we have around 5,000 cities. We have 27 states, including the capital city. And we do have this intermediate level, which are the intermediate regions. And we are using as sentinel cities, the largest city in each of these regions. So we do not claim this sample is representative of the Brazilian population, because it does not include very small cities, but it does give a brief overview, a good overview of how the epidemic looks like in all states of the country. So this is EpiCovid-19 Brazil. And our design, the first wave of that data collection ends today. So at 8 p.m., we will be done with the first wave of data collection, second data collection in 2 weeks' time, and then the third one in 2 more weeks. And again, the Ministry of Health is already interested in funding this study to have more waves of data collection. I want to spend 2 or 3 minutes telling you guys about the fieldwork challenges we are facing. So, like the main television channel in Brazil had a very long story about this on Sunday, because in some of the cities, our interviewers are having a hard time. You know, it's a difficult time. In some cities, local administrations are not really, let's say, happy with having their data publicly available. So interviewers are having a hard time, but we are still doing the field work, and we will not get 33,000 interviews and tests, but we will get around 25 or 26,000. So in each of the sampled cities, both for the state study and for the national study, we randomly select census tracts, which are small areas in each city comprising approximately 300 households each. This is defined by the Brazilian Institute of Geography and Statistics. And then within each selected tract, what we do is that we systematically select households. So let's say first, then 11th, and so on. So pretty much that's the sampling scheme. So it does represent all regions of each of the sampled cities. And the number 33,000 is a multiplication of 133 cities times 250 interviews and tests in each of them. And this is pretty much what we are doing. This is last night's update on the progress of the field work. So we are about completed. Data collection is about 100% completed in Acre, Amazonas, Sergipe, Amapá, Rio Grande do Sul, Tocantins. It's pretty well advanced in other states, and it's having a hard time, particularly in Paraíba and in Pernambuco. Those are the most difficult ones. And the only result we already released was this, and I'm sorry because this is in Portuguese, but this is the only city for which we already released the data. And we did that for two reasons. First, because Manaus, the state capital of Amazonas, is probably the city in Brazil with the highest incidence of disease and the highest mortality. So we had the data and we already released it. But the reason I'm showing this slide is just to say that for each of the 133 cities, we are preparing a card like this. So data are not fully correct here, but it's just to show the model what we will do. So pretty much we will show where the state is, then where the city is in the state, population, the geographical area. Then we show the iceberg theory, which is like the logo of the project. So that confirmed case represents just a small fraction of the entire iceberg. You know, most cases are underneath the water. So just using the Manaus example, the number of confirmed cases is 10,000, and our estimate based on our study is over 200,000 cases, which means 20 times more cases than confirmed statistics. And then if you go to the right hand side of the country of the city card, you will see that in Manaus there is one person already infected for every 9 people, and the prevalence estimate is 11% with a confidence interval from 7.6 to 16%. If you go to the literature, there are very few places in the world where you find a prevalence of 11% or more. If you look at the Spain data that was released last week, or the New York data, or other places, you know, in the city of Gangout in Germany, it was 14% at a point, but you know, most estimates are much lower. And then we will also present the results for social distancing. This is not 100% accurate, so this will be updated after the field work is completed. But the idea is to show proportion of people leaving home every day, proportion of people that only lives for essential activities such as drugstore or supermarket, and then the proportion of people who stays at home all the time. And we are planning to release the preliminary results tomorrow evening. We are not sure whether we will do that or not still, because we need to clean the data. Obviously, more complex analysis will not be done in 24 hours, but at least, you know, face prevalence values, we are looking to let people know very soon for ethical reasons, and then and also to help plan policies, health policies, and also to help other groups who are modeling COVID in Brazil, and they do not have this data yet. So we want to help by providing this data. So I think that's it. Thank you very much.
Okay, Pedro, thank you very much for your talk. It was very interesting. I'm not sure. So I will start with the questions. We have a lot of questions from the audience and between the speakers. And I will start with some questions coming from the speakers. And for example, there is a question by Dr. Viboud to Dr. Bhatt and Mellan. Are you listening to me?
Very much so.
Okay. So the question is, did you find predictors of difference in R0 between Brazilian states?
So it's actually quite a challenging thing because of under ascertainment very early on in the Brazilian epidemic, with many deaths being missed or being miscalculated. I don't know how reliable it is to actually check whether the differences in R0 really reflect underlying contact patterns that could perhaps influence the reproduction number early on, or whether it's just a function of the data being missed. So I think, Tom, correct me if I'm wrong, but we don't see huge differences, especially when factoring in our credible intervals for Brazil.
Yeah. No, that is fair to say. I mean, across the different states, we're seeing a similar R0 right at the very start. There's no substantial differences or trends that I can pick up anyway.
Yeah, but I mean, we do see these differences in other countries, though, which I guess is interesting in and of itself.
There is a question by Professor Levitt to all panelists. Japan seems to be an outlier with an aged population and high density. What is their secret? Could it be universal face covering? So I'd like to ask, for example, Dr. Viboud to reply to this question.
Yeah, I mean, I don't know of any good population level studies of the Japan data. I mean, we've looked at it a little while ago. It's very, very heterogeneous. So it seems to pop out in a few places and then disappear, pop out somewhere else. And there is face covering in a lot of Asian countries. So Japan is not exclusive, in wearing masks. But I do agree, it's the whole Asian experience is interesting to look at. And that's one of the countries that maybe hasn't been studied enough.
I would also be curious to see what the contact matrix looks like, because the aged population is important, as we can see for Italy, but it depends on who and then the frequency and the flux of these aged people interacting with other members of the population that are perhaps having other contact matrices. So looking at the underlying contact matrix and the pattern there, it would be curious. But yeah, I wouldn't know enough about Japan to conjecture about their outbreak there.
May I just say one thing? I wrote a paper for a Brazilian journal in which I compared data from 78 countries and territories, and we correlated deaths per million with life expectancy and with density. And we found a strong correlation with life expectancy, and we found no correlation with density, population density. So this is important to keep in mind because, there are some small countries like San Marino, Andorra with very high numbers per million, but this is noise because they are really small. But when you look worldwide, there's no clear pattern that you have higher mortality according to population density. Actually, the correlation is 0.10, I think, while it is 0.50 for life expectancy.
Can I just ask, this means that if there's a longer life expectancy, there's more deaths or less deaths?
More deaths, which is...
no, I understand.
Yeah.
Let me ask another question.
I stimulate, the panelists. We can do a round table here. Please.
Okay.
Be free to
So
ask.
I wanted to ask a question. In Europe, there was a very, very weak flu season in this past winter. So, and the winter before. So 2017-18 was bad, 19 was less bad, and essentially there was no flu in Europe this last flu season. So that would suggest that people who would otherwise have succumbed to flu were still alive when COVID hit. I wanted to ask, in Brazil, what was the previous flu season like?
I'm sorry, Professor Levitt, but I don't have the data. I need to check because I did not look at these data already. What we are using most of our time is to look at deaths in the last 2 years because we want to compare with this year to check the degree of underreporting, but I did not look at flu data separately.
Pedro, I'm not sure if you are aware, but people from São Paulo and some working in my university just released, the results very close to you. And in São Paulo City, doing, the same methodology as you use in Rio Grande do Sul, we found 5.2% of the people with antibodies. And we choose, the sections of the city where the mortality is higher. And so São Paulo is intermediate between Rio Grande do Sul and Amazonas.
This is very interesting, Rui, and this is why I was mentioning these studies, because we do have the study in São Paulo, we do have one in Espírito Santo, we do have in Ribeirão Preto, in the state of São Paulo, then we have people planning other studies. So there are lots of serological surveys taking place in Brazil right now, and it would be good if those folks doing international studies using Brazil, that they interact with us, because there are lots of data out there that we can interact and help the models.
Can I just note one thing with regard to your relationship on population density? So that there is an ecological fallacy here, right? If you look at population density, and I'm really guilty of this to some degree as well, but when you look at population density on a country level, that's a rather meaningless metric, right? Because somewhere like Sweden would have very high population density in Stockholm and absolutely nothing further on. So really what we're using is proxies for contact networks, proxies for how much people interact with each other. And in that setting, that's where population density becomes a big thing, right? So, it's not surprising to see a spurious correlation at a national level or a spurious correlation with regard to age, life expectancy, because, conversely, an argument can be made that if comorbidities are a driving factor for mortality in COVID-19, then the healthier a population in terms of non-communicable diseases, the more susceptibility they have. And so more sort of life expectancy is correlated with higher resilience to various comorbidities because of a healthier population. So it's a very difficult metric to sort of disentangle. In our work, we just step away from the causal explanations and just say that, well, there is heterogeneity in R0. And I think as a scientific community, people need to understand that R0 is really not this fundamental constant of physics. It's something that can change by...
No, I completely agree. This is the reason. This is not even part of the presentation. This is just, I was just mentioning that we did that correlation. It's not like we are fully aware of the biases associated with the ecological thing. We are just mentioning what it did look like, but obviously we will have a much better sense when we compare, for example, within Rio de Janeiro in Brazil. If we look at the favelas where people live really close to each other, then we will have a much better sense on agglomeration and the spread of the disease. That's absolutely right.
Okay, I have a question. This question came by Professor Levitt, and I will ask this question to Pedro or to Sam or Tom, particularly because they know very much about Brazilian data. Why is Brazil being hit so hard? Could it be because it is equatorial, the same region of the world where flu is endemic, or maybe, please feel free, to comment about, some kind of political reasons, in my opinion, because a clash between it looks like United States, there is a clash between the presidency and some governors. I think this is very important, and the people is somewhat confused regarding who want to follow.
I mean, again, you know, it is. I personally would not comment on sort of the political arguments. I would say that Brazil is getting hit very hard because the reproduction number and all the best estimates we have of it are above 1. Now, if it's getting hit hard, there's an argument to mitigate or slow things down completely. I'm not going to sort of retrospectively comment on counterfactuals sort of now in this forum. Maybe Tom might have more to add, but you know, I think the one thing that, you know, it sounds like a cop-out, but you know, it's a scientific fact, right? I'm not going to speculate on various conjectures, but I'll say that the reproduction number under every scenario that we seem to test is above 1, and that needs to be acted on. That's a fact there, rather than sort of looking at various other conjectures about what could happen, what couldn't happen. We're telling you that now. That's something that needs to be actioned upon. What needs to happen, what will happen, that's a decision for decision makers. As scientists, we can just inform about what's happening on the ground now and allow decision making to the people whose full-time job is decision making.
So yeah. Professor Rui, let me comment on that too. So first of all, we need to define hit hard. So this is the first thing, because when we look at mortality adjusted for the size of the population and adjusted for the stage of the pandemics, Brazil is intermediate. Brazil is doing much better than Europe, and Brazil is doing much better than the US.
Pedro, you can't say that with the reproduction number in Europe being 0.6 and the reproduction number in Brazil being 1.5.
Yeah, that's absolutely that's absolutely an opinion that you can have, but you know, I think we need to look at the reproduction number more carefully. What I know is that from the data we do have on mortality adjusted for the size of the population and mortality adjusted for the stage of the pandemics, so number of days since the 10th death, Brazil is going better than these countries. Obviously, it can happen that in the future it will get worse. And I think the reason for that is that we adopted social distancing very early, and this was good news. And obviously, I'm concerned, as the colleague is concerned, with today and the future, because data does suggest, and I agree with the colleague, that data does suggest that if the reproduction number continues to be this high, our curve will not go down at the same time as it did in the other countries. And this is a big deal. So I think we need to be careful. We need to have, the Ministry of Health will need to have social distancing, good policy on this. Obviously, I do not think there will be 1 million deaths in Brazil. This was said in the past, but I do believe that we need to be careful about what we will do in the next few weeks. Otherwise, it is possible that we'll be one of the few countries where data will not start to go down at the same time as it did in other countries.
Perhaps this isn't a scientific statement or not, but you know, the objective criteria for what is doing better and what is doing worse is, of course, very difficult to define, right? You know, when people say better, your criteria is the deaths per capita, right? But you know, it mustn't be masked that loss of life is loss of life, just to sort of divide by per capita, you know, accepting the fact the reproduction number is above 1, accepting the fact that, you know, we've said this, you know, the reproduction number has reduced in every single Brazilian state. That is not, with all our scenarios, all our model caveats in there, that's what we think happened. But that doesn't mean that the reproduction now is by any means under control. And I mean, I can let Tom sort of state, you know, he looks at the data every day, you know, waiting for this curve to bend and waiting for our model to sort of prove to us that we're wrong. You know, we're not oracles of Delphi. We're just trying to summarize as best as we can what's on the ground. So, I mean, Tom, you might have something to add.
Yeah, I mean, just to say, I mean, I don't think it makes sense to look at Brazil as a whole and say, why is Brazil so bad? Brazil as a whole isn't so bad. Lots of states, the epidemic is at a very early stage and the deaths per capita are very low. But in some other states, like Amazonas, they're extremely high actually. And across every state, we see a reproduction number that's above 1, suggesting that the interventions that have affected how people change their mobility, haven't been totally effective. I mean, if we look at mobility in Brazil compared to in European countries, we see that the mobility is much higher after the government interventions. So that's perhaps part of the reason why the reproduction number is still above 1, according to our estimates in lots of Brazilian states.
Michael?
Having asked the question, I certainly agree with Pedro that I think Brazil seems very bad because it's sort of the last place that is still, I mean, if we'd seen Brazil against Italy a month ago, we would not have said the same thing. One thing you were mentioning that Amazonas has a very high population mortality rate. Is it more than 1 in 1,000?
It's not over 1 in 1,000. I think it's about 350 out of 1 million.
So it's still less.
Yeah, that's right.
Yeah, Dr. Levitt, according to our population-based data, by testing real people and having the data, the infection fatality estimate for Manaus, the state capital, is 0.4%. So 0.4% is the infection case fatality for the state capital.
Right, but the population fatality?
But that's a meaningless quantity, given that you don't know testing correctly. If you
I'm just saying, I'm not talking about, I'm just saying how many people die per 1,000 population.
Oh,
that's
okay.
a number that is big. That's a number that is irrelevant.
Yeah, about 0.35.
So this is what
it's basically it's 7 times less. Yeah, so it's 7 times less than New York City.
Yes, but
exactly.
New York City. Brazil's epidemic hasn't started yet.
No, I agree. I'm just saying. I'm basically rephrasing. I'm putting my question, which I think was probably unfair, into perspective. Brazil has a population of over 200 million and so on. So I think there's a lot of psychology here. And early on, 100 deaths would have got a lot of news coverage. And right now, people aren't looking at anywhere else except Brazil because it's still going on there.
And Dr. Levitt, let me just comment on one thing, because I did not understand the argument about lack of testing. This is not lack of testing. This is not official data. What I'm telling you is that based on the population prevalence estimated through a real survey of real people, we can estimate that we have 4 deaths for every 1,000 people in the state capital of Amazonas. That has nothing to do with limited testing, which is a big Brazil.
Limited testing always seemed to me to be a political question, not a scientific question. At very early on, I wrote that if you wanted to waste enough money, you could do PCR on everybody and you would find more and more cases and it wouldn't prove anything. This is why I think the Imperial Group's use of deaths is a very, very good idea. I think that, I guess, I just want to say personally, I would have loved a discussion like this 3 months ago, but I guess it wasn't possible. Anyway.
Let me change gear a little bit. Any one of you have any hint why kids are less infectious prone to get infection, or rather?
I mean, I don't. I have absolutely no idea. I mean, it's not an uncommon thing. I believe it's hepatitis A. You can only really observe through adults. Don't quote me on that. I can't remember what it was. And you see this in veterinary animals as well. There are many cases where there's, the response is different in kids versus adults. COVID-19 is not something very specific. But
I think Professor Viboud had a very good data on that. She presented some of these data. It would be cool to listen to her opinion on that.
But,
I mean, I think the jury is still out. Our own data indeed suggests that there's, children are less susceptible, perhaps a bit less infectious. But, if you look at different data sets, like there was one from Shenzhen in China, it suggests that, children are as infectious and as susceptible as adults. I mean, clearly we've seen outbreaks in schools. In France, there's been nice studies there. So children can get it. I think it's pretty well established everywhere that if they get it, their symptoms will be less severe. But the susceptibility, infectiousness, I think we still need more data on it. If anything, it points toward a slight, under risk. But I think we need more data. And so I was curious actually on this about your serology data. Have you broken it down by age? Do you see interesting patterns?
Yeah.
We will do it as soon as we have the data. So data will be available tomorrow. So we are crazy to do it. And we will break down by gender, by age, by race. And we do have socioeconomic status in the survey. And then we do have very interesting question on symptoms. And this will be cool because we will have an idea of what proportion of those with antibodies had no symptoms at all, or just mild.
I have a question for Tom and Sam, since you know very well the data for São Paulo city, and maybe I'm sure the mayor of São Paulo is following, each day, the data that come from Imperial, and I think the mayor have a very good idea. The idea was to anticipate, the holidays. I'm not sure if you are aware of this, because, to put a lockdown in the city, it's complicated. São Paulo is very huge, like London, it's a metropolitan area, very, very big. And so he decided to anticipate, the holidays. Since the Brazilians, like a joke, they are saying that maybe next week will be Christmas here. But what do you think about this idea? I think it's a very good idea. It's because since the worst scenario is probably the next 2 weeks, if you have some kind of anticipation of holidays, can be a good measure. What do you think about it?
I mean, it's a very, I would say that we're reasonably ignorant about this. At least I am. I wouldn't say that I would know what would happen in holidays. I mean, it's everything that we're doing here, at least in our modeling, is relatively crude because we're trying to account for proxies for transmission, right? We don't actually know the contacts, networks, and the people actually doing this. We're just trying to get proxies for this. And so, if holiday transmission makes people stay at home a lot more, that's a good thing. If people travel between regions, that's probably a bad thing. But I mean, quantitatively, for me to say anything, I would say I don't know. I mean, maybe Tom might have a better opinion on it, but I would be curious to track and see the effect of this. I could say that.
Yeah, I mean, it's difficult to say, but just to note that we do see a large effect associated with parks, which would include beaches, which I'm guessing people will go to on their holidays. So, I mean, in terms of the data, we can see that if there's a reduction in the amount of time people are spending in these social spaces, this reduces the reproduction number. How exactly that will fit in, or how exactly you can build a policy around that, it's difficult to answer though.
Okay, I have a question from the audience about, if in these studies there is a consideration for previous nutritional status related to the severity of COVID-19. Pedro?
Yeah, our studies, our prevalence studies do not include any data on prognosis of the disease. So probably, I think the person who showed more data about what the severity of the disease looks like was Dr. Viboud. I don't know whether, Cécile, do you have any data on the influence of nutritional status or not? I'm not aware. I did not see anything on that already so far.
Yeah, no, I don't know. I mean, maybe as the epidemic reaches Africa, we'll have more, but I don't know of any data. Yeah.
I mean, we confounded through comorbidities as well. They're very difficult, a very important question from the audience, but I think one that just stresses that we need to do more research on this and understand it, to be honest. As far as I know, I don't have an answer on this.
Okay. Michael, go ahead.
Yes, okay. My phone rang and my phone is used as my modem, so I had to go and turn the phone off so it wouldn't interrupt. Forgive me. Everyone is using this word R. I got a simple formula for R. I mean, I know how to program computers. How many lines is it? to write a program to calculate R from number of deaths per day? Is it an easy calculation or is it a hard calculation?
If you use that formula that I sent you, that my colleague Jeff Eaton sent me, it's one line of code.
Yeah. I understand, but can I trust that? That's an approximation. Is it 2 points? There's a power of 2.6. Is that because it's a power of E? I'm trying to say, using a formula like that is really scary.
It is.
Is that what you? But let me ask you: do you use that? Does Cécile use that?
No.
So then, what is? So is there a thing? I guess what I'm saying is that a serious problem here is that it's very easy to calculate the exponential growth rate. It's very easy to calculate the ratio up to data yesterday, but epidemiologists are using a measure that is very well known because of movies. Everyone knows about R0, but no, it's a very hard calculation to do. Can you send me C code or Python code or Fortran code to calculate R from a trajectory?
Well, there's a lot to unpick there. So please do stop me, Rui, if I talk too much. So first of all, it's not easy to estimate exponentials. There are many pitfalls that many people do. For example, fitting to cumulative data, it gets the variance wrong. You're violating the IID assumption in your likelihood, number one. Number two, as the seminal paper by Clausewitz showed, trying to estimate the growth parameter using maximum likelihood is extremely difficult because it's very sensitive. Small change in the growth parameter can give you a very different change, and many growth parameters can give you the same curve as well, number one. Number two, the reproduction number arises from highly theoretical aspects in epidemiology. So it says, let's create a stochastic process where one person infects another person, and let's look at the generating function of that stochastic process, and that's where the reproduction number arises. Or let's look at compartments of susceptibles infected and recovered, and that's where the reproduction arises. There are a lot of assumptions baked into this reproduction number, and things like a uniformly mixed population, completely susceptible population, all these things are into this reproduction number. It's not something that's trivial to calculate. It is something that I think it's too focused on because, you're trying to create a summary metric for transmission rates. It's a rate summary at some point. And so the equation that I gave you, or my colleague Jeff gave me, it's from the seminal work of Jaco Wallinger and Mark Lipschitz, and they take exactly the same approach as we've done before, using a renewal equation or renewal theory. They say that the early part of the epidemic is exponential growth, and based on that assumption, they use the moment generating function to basically create this singular equation. So if you fit a log linear line, and you take the growth parameter from that log linear line, and then you put it into this formula, which is assuming a serial interval distribution of 6.5 days, not 7 point something, which we could change, then that equation will give you a rough estimate for R0. But there's so much baked into that assumption just now that I told you, that exponential growth in the early phase and all these other factors that it's complicated. So in our approach, we think we have some way. We don't call it the basic reproduction number. We call it the starting reproduction number. It was the rate at when you started.
So let me ask, there's an R0, but people also have an R of T. In other words, I saw many graphs that both Cécile showed and you showed where there was R varying with time. Is that an easy thing to calculate?
So, R0 is supposed to be the situation where in traditional epidemiology, R0 is completely mixed, completely susceptible population.
But what is R of T? When you show
R of T is when more people get infected, they become susceptible, and so the reproduction number will go down by itself anyway.
No, I understand, but if I have a list of cases as a function of time,
R of T.
How do I calculate R of T?
You pick a region of your case data that you think is fine and fit your growth rate to that region. Essentially, trying to get the derivative of your function at each point can then give you.
So your R of T is just the slope of the log number of cases.
Well, if you're going to use that formula there, we use R of T within this Bayesian semi-mechanistic mechanism. Okay. So it's not like that for us. But if you were someone fitting a curve, you would choose an initial part of the data, fit a log linear, that rate is your R0. Then as the curve starts bending,
I understand. But I'm still, I guess I'm still puzzled by the sociology of using a measure that is hard to calculate, hard to define. For example, you know, if I asked you, what is the R of my bank interest? You could probably calculate it for me. Or what is the R of the dollar interest rate in the market? It's a time series, and I guess you could do that. I guess I'm just concerned that something which is essentially describing the way the growth changes as a function of time is so hard to see.
Because you know, it comes back to, do you want something tied back to how we think an epidemiology works, or do you want something that's just a summary of it? You know, when you talk about the growth rate in dollars, it makes perfect sense in that sense. When you're talking about R, it emerges from fundamental epidemiological theory, and that's why it's useful. It's useful to calibrate against other diseases. It's useful as a summary of the infection process, right? You know, we call it R. In physics, you would call it the critical doubling, which you would use for nuclear physics, for the neutron split.
So it's the same as the critical doubling?
Well, it's similar to that, right? You have a critical. You're either below a threshold of 1 or you're above a threshold.
Well, but then the ratio of cases to data yesterday also stops at 1. I mean, many things stop at 1. I mean, if the number of cases today is the same as yesterday, that also stops at 1, and it's a high number. I guess I'm just very puzzled by this opacity, which I think has led to a lot of misunderstandings. And you know, I can see that within a field. I mean, I'm in a field that we use Fourier transforms and all kinds of things all the time. But you know, and my simulations involve millions of variables, time series, integrations over long periods. But somehow, ultimately, I've always said that the key thing is to translate 1 billion numbers into 3,000 words, maybe in nature or science. But you know, it's I don't know. I guess I'm concerned by, there's been a massive communications gap here, and you know, one question that I did raise that the Rui didn't pick up is, I've noticed, for example, that epidemiologists, and I'm not talking about you guys, don't think anything wrong about being a factor of 10 too high, but are dead scared to be a factor of 10% too low. And this has caused, I mean, the number of deaths being caused by lockdown is way higher than anything that will be caused by COVID, unless you assume exponential growth forever. So therefore, this is a price that the world is paying for this asymmetry. In other words, I don't know how we handle it. You know, Sweden is not locked down. You guys are going to have a very hard time when Sweden plateaus at 6,000 deaths, which is 0.6 per 100,000. And you can say, well, they're social distance, they're Scandinavians, they're cold, there's high population density. But you know, the fact remains that the plateau rate of population reached by England, New York City, Lombardy, France, is basically around 1 month of natural death. Ferguson said a year of natural death. That is horrible. That's an error that is cost the world many, many trillions of dollars. That isn't a joke. I mean, an error like that is not a small error. Now you could say, oh, it's our intervention. We intervened, Sweden intervened by itself. Italy was a very intervened country. Anyone who believes that Iran intervened is crazy. Certain countries, there's no doubt that the one place where there was beautiful intervention is a part of China I call non-Hubei China, which is the area that Cecily studied. In Hubei, the Chinese were out of control, but out of Hubei, the epidemic is the most beautiful Gompertz function. It was so beautiful that everyone said they must have hacked my computer, except that New Zealand has the same distribution and other countries do as well. So I'm trying to understand this. There's no doubt that once lockdown has been forced, everyone's going to believe it was a good thing, because otherwise, why did we do it? But there's no evidence for it.
It's not about believing if it's a good thing. What mechanism do you conjecture for the plateauing of deaths in the UK that's not lockdown?
It reached 1 in 1,000. It had nothing to do with lockdown. You managed to, the UK policy led to early saturation. The whole country was infected before lockdown was done. Same thing was true of New York.
No serological data supports this hypothesis.
Well, this is going to saturate at 20% serology. We know that already. I mean, you know, this assumption that it's 80% based on R0 is basically nonsense. You guys are you don't know what you guys are doing to yourselves. You guys are going to end up being responsible for $100 billion crisis to the world. And this is not funny. And you start to use clean terminology. Don't estimate herd immunity from an R0 value, which is completely meaningless. If the R0 value is 1.3, then I get saturation at 25%. The Diamond Princess, this wonderful experiment, saturated at 25%. And you can say, oh, it was such good lockdown. We had shared air conditioning. We had an aged population. It doesn't work. In other words, there needs to be sanity checks. And the sanity checks come from looking at the data.
So okay, well, we're going to talk about the data then. So your hypothesis is that infection fatality rate is much lower. Everyone has been infected. That's what caused the curve to bend. A massive serological study occurred just now in Spain, suggested that with the 28,000 deaths, 5% of the population has been infected. Big serological.
And I think we've seen that serological studies. We've seen that serological studies have serious shortcomings. We're now seeing signs that there may be T cell receptors.
Where's the evidence on your side of the equation? Where's the
evidence?
Okay, people.
Can I say something?
We run out of time, and I would like to maybe I'll have 1 minute for each one of you. Cécile, did you like the webinar, please?
Yeah, I enjoyed it very much. And I think, these are all good discussions. I mean, we're all scientists in the end, and we try to explain the data. And it's great to also hear from other fields. I mean, the economical issues are huge. And I think as epidemiologists, we don't consider them, but we feel them, individually and personally. So they're really strong. I think we should all wait for the second wave. And there, that might tell us who's right and who's wrong. But, we're modelers. And when there's new data, we just update our views of the world. And so we can do that too if we're completely wrong.
Okay, thank you very much. Tom?
For inviting me. It was really good to hear everybody else's talk. Oh, can you hear me? Oh, yeah. It was great to see everybody else's talk and to hear about the serological data coming out of Brazil. That looks really excellent. And to hear about some of the questions from the audience. Thanks very much.
Okay. Sam, please.
To engage and discuss with everyone. This is the way science is. It should be an open discussion with everyone listening, and absolutely no censoring of people's opinions. I'll say that as a scientist, I would absolutely love if everybody has been infected and this was over. I can go out and have a beer. And if that is the case, I will publicly come out and say, as a scientist, yeah, we got this wrong. Sorry, we got it wrong. Let's do things in the future to ensure that we don't get it wrong again. I would encourage that others take this exact same approach. And as scientists, we have to acknowledge we don't know everything, but science is underpinned on being open about being right and wrong. And I really would like to be proved wrong. And I will say it shamelessly, right? It's not a reflection. I used the science best I could. I used the math best I could. I used the data best I could. There's a lot of things out there. So that's, I think, the only thing I would say is that acknowledgement of this is important. But I'm happy to have the discussion always, with such esteemed colleagues as well. It's
Thank
phenomenal.
you, Sam.
Can I just echo what Sam said? I agree completely. Discussion is incredibly important. I sent my reports out very broadly. They're publicly out there. Getting discussion from anybody has been incredibly difficult. This is the best discussion that I have experienced. I have learned more in this discussion than anywhere else. I've been on a lot of panels where everyone agrees with each other, and that's ridiculous. This has been a terrific study. And I think this will go down as being a really landmark panel where we had different views, lots of very great science, and thank you so much. It was superb.
Okay, thank you. Pedro?
So first of all, let me just say, Professor Levitt, that no one gets, I'm very proud to be here with you and discussing these issues. I do disagree with your idea that everyone is infected every serological survey shows that the curve starts to go down around 10 to 15%. And the problem is that it is likely there will be a second wave as we had in the past. And I agree with Professor Viboud that this is our main concern. In terms of our reproduction numbers, my main problem is not with the reproduction numbers per se. My main problem is if we want to know the weather forecast, we do not check the weather forecast for the next 3 months. We for next week or for tomorrow. And I think that when it was announced that Brazil would have 1 million deaths due to COVID, it created panic, and it was very difficult to deal with, and it was worldwide. So I do think that we need to be more careful about presenting these long-term forecasts for something in which our precision is very good only in the short term. Thank you very much. It was a very good discussion, and all the Brazilian research community, and I'm sure I'm talking on behalf of other colleagues, we are happy to collaborate with you guys from all the groups to help understand this scenario more closely. It will be much better if we work together instead of other countries looking at Brazil without involving us. Thank you.
Okay, thank you, Pedro. Before I pass the microphone to Luiz Mello, I'd like to tell you that I received many congratulations for the excellence of our speakers. So thank you very much for all of you. Please, Luiz, close the.
Just to echo, as everyone mentioned, this is how science should be conducted, is discussing and it's proposing arguments from one side and to the other. And eventually we may reach consensus, and we definitely will learn more out of this interaction. FAPESP is very honored to open this set of sessions with this distinguished panel of speakers. And this session was specially designed to bring different views and perspectives. And that's exactly what we got. And so, again, we're very happy to have achieved what we aimed for. We hope the next session, the series of sessions, might be as successful as these. And again, we're honored to have you all here interacting with us. And the main aim of FAPESP by having this is to motivate scientists from different fields to be together and contribute to understanding and providing a better understanding of what we're currently all experiencing in the globe. Thank you all.
Thank you.